My first guest is Dr. Alex Howard, who is a gastroenterologist with Baptist Health. Welcome.
Hey, thanks for having me, Jeff.
Well, Colon Cancer Awareness Month. Who's at risk for colon cancer, and when do you start screening?
It's a good question, Jeff. Everybody's at risk. The strongest risk factor is actually just getting older. Roughly the average risk patient at the age of 50 should be offered a colonoscopy.
Does that change as you have a different family history?
Absolutely. That's probably the strongest risk factor other than age. If you have a family history of colon cancer, particularly a first-degree relative before the age of 60, you should have that colonoscopy done 10 years younger than the age of the person diagnosed with colon cancer, or at age 40, whichever comes first.
Now, you mentioned colonoscopy. There's other ways to screen, but we're going to talk specifically, at least initially, about colonoscopies tonight. So, normal colon, okay? Everybody, they complain about the prep, okay? They don't want to have the prep. Why is the prep important, and is there an easier way to do it?
Well, you know, it was a good learning experience I had at the university. I had a case where I was doing a colonoscopy and the prep was not adequate, and the indication was for anemia. And the next day we got the better prep, and actually we had missed a mass. We had actually gotten through the whole colon, and you could miss a big, large mass. So the prep is probably the most important part of the colonoscopy, and this is what we would see as going in with a high-definition scope, and this is the triangular folds of what's likely the transverse colon, and we're not going to miss any flat lesions. You know, you can see lesions that are 2 millimeters, 3 millimeters flat, and you could really miss a lot if the prep's inadequate.
So when you talk about prep, it's important because you've got to clean all that out so you can see.
Yeah.
And if you don't, you could hide a polyp, you could hide a lesion that could lead to catastrophe down the line.
Absolutely. Now, the dreaded prep is the funny one name called Go Lightly. You take basically a gallon of fluid, tastes like lemon-lime Gatorade, salty lemon-lime Gatorade, and it is tough. But we have other options. Some of those cost a little bit of money, but we have cherry-flavored ones, we have mango-flavored ones, we have different flavored ones, cranberry.
So even though they dread it, it's important because you want to get a good exam.
Absolutely.
All right, now this is a normal colon, but sometimes you see a polyp.
Yeah.
Tell us is that what we're looking at there?
So one of the questions I get before we go in is, what is a polyp? And a polyp I'd like to describe as a wart. Now you can see that doesn't look necessarily like a wart, but it's a growth, and you can clearly see that these folds kind of come down, and then you've got this bump here. And that's what a sessile, that's how we would describe this polyp, would be a sessile polyp. Kind of lays low, and in a minute we'll show you one that looks pedunculated.
Now, you can have more than just one, too.
Absolutely. And these are, you know, you've got one there, and when you have a polyp at this number, I start thinking like you might have a genetic tendency to grow polyps, and getting out just one, we might need to talk about a genetic counselor, actually, when you have this many.
Now, polyps can be bad, be good. Are there different kinds of polyps?
Yeah, so it's a good question. Polyp, the two main differentiating types would be a precancerous polyp or a non-precancerous polyp. A non-precancerous polyp would be what you look at under the microscope, be a hyperplastic polyp in the rectum. Those don't go on to colon cancer. We have pretty good data that they don't go on. But the other ones, most of them, are precancerous. And the two most common ones are tubular adenomas and sessile serrated adenomas. Sessile serrated polyps kind of look like hyperplastic polyps, but they're on the right colon. They tend to be, and in my opinion, they grow faster than the adenomas. But if you want to break it down, a polyp morphology, describe it as sessile or pedunculated. It can get much more complicated than that. Precancerous or not precancerous.
And that's one thing with colonoscopy, you can actually see the polyp and take it out right
Absolutely,
there at the top.
Yeah. I cut them all. It's recommended to cut them all out, whether or not they're precancerous or not. This is a nice pedunculated polyp. You see a stalk. This endoscopist, the tools come out the 5 o'clock position on all scopes. I like to actually rotate to get the polyp in the 6 o'clock position. Makes my life easier. This guy's taking it a little challenging, but he's going to get this polyp at midnight. I like to also, when you have a pedunculated polyp, cut off about a third of the stalk, because you never know how deep that precancerous change goes in. The closer you cut it off to the wall, the more likely you could get a transmural burn. So we like to...
You cut that off and you get it and you test it.
Absolutely. You take it out. That one looks too big to be sucked up with a polyp. We have nets that we can catch it and pull it out. We have tattoo agents where we can tattoo the lateral wall, so the next colonoscopy we see that area, and we can examine that mucosa, and so that's helpful to identify.
And if you don't get these polyps, it can end up something like this.
Jeff, this is a problem. This is going to be this is definitely a colon cancer. You've got ulcerations in the middle. You've got almost near obstruction of the lumen. Yeah, this is what you want to prevent. And it's been thought that a typical polyp to cancer rate, if it's a precancerous polyp, takes about 10 years. So this individual might have had an adenoma that had taken 10 years to develop this.
So if you have a polyp on your colonoscopy, you don't want it to develop this, so you probably want to shorten your interval between colonoscopies.
Absolutely, yeah, and the size, the number, the prep quality, family history, the endoscopist has to take all this into consideration with the interval recommendation.
So you end up with colon cancer. There's different levels of colon cancer and different treatments.
Yeah, so the name of the game with colon cancer is the depth of invasion. Okay, so stage 0, you're limited to just that layer. You got layers in the colon. You got the mucosa, submucosa, muscle layer, and then the serosa. So basically 4 main layers. Stage 0, when you do a colonoscopy, that's the gold mine. That's what you want to find, because you just do a mucosa. You just put a snare around that. You cut it out. The pathologist confirms you got clean borders, and if it's not poorly differentiated on the pathology, then you've cured that patient of colon cancer. That's the holy grail of colon cancer. Now, the stage 1, it goes into the submucosa a bit. That one's problematic for endoscopic resection. But you can do an endoscopic submucosal dissection, or sometimes you can lift it out and you can get it. But the key thing is margins and depth. Stage 3s and 4s, you're already talking lymph node invasions, and that's the problem, because if you get in the lymph nodes, you do worry that you're going to need to get them with chemo. And
so you want to get it back here.
Absolutely.
And get it early, and that's why you should have your colonoscopy this month, Colon Cancer Awareness Month. We'll be right back.